Welcome to Discovering with Dr. Deb. Our last season, we were discovering the Enneagram with Dr. Deb, and it was packed with a lot of information while also being a lot of fun to talk about and explore the Enneagram and why we do what we do. So go back and check out those episodes if you haven't seen them already. Here we are in season 2, and I'm going to be focusing on trauma and using EMDR therapy as a tool to help process trauma. My co-host for this season is psychologist Dr. Christie Sprowls from Austin, Texas. She has traveled all over the world to provide EMDR in humanitarian efforts, and she has also trained clinicians and providers in EMDR therapy. So get ready, let's dive right in and talk about trauma. Hello, we're here for another episode of Discovering with Dr. Deb. I'm here with Dr. Christie Sprowls, and today what I really want to talk a little about is when clients come in as a provider, and we've got a client, and maybe they're presenting with a whole host of things. It could be anxiety, or it could be depression, or it could be grief, or they may identify it as trauma. So there's not a cookie cutter way that we're going to kind of look at it. We're not going to go, oh, boom, here's what we're going to do. So there's ways of looking at it. We call it in the field case conceptualization, correct? Right?
Yes.
So help me go through kind of what is our thought process when we sit down with a client. Sometimes I think we've alluded in other episodes that there's this perception. We talked about this when we did myths about the EMDR. They're going to come in and we're just going to go, okay, follow my fingers.
Yes.
We're going to just jump into like bilateral stimulation. But there's a lot more to that, right?
There is.
So I know, and we do this a lot when I'm certified in EMDR, had a wonderful trainer. And we do that. We do this a lot. We do this case conceptualization when we're kind of unpacking and kind of getting feedback, like where do we go with this client?
Yes, exactly. Yeah. So one of the things that I like to tell people when I'm teaching is that, look, somebody's going to come in. They're going to have a reason they're coming in.
Right.
Because people don't just go to therapy for nothing.
Right. There's something that's prompted them to get help now.
Exactly.
Right.
And I'm as interested in the now as I am in the history.
Right.
I take a history, which means I just explore their worlds, and really I have them do a timeline of their life. I like that a lot because what it does is it gives me the lay of the land.
Right.
That if we're working on one particular memory.
Right.
So we have this idea of case conceptualization. Do we just do the one memory they come in with,
right,
or the one thing that's bothering them the most, or do we do a more comprehensive approach? And so we get all the information, and then generally speaking, we'll start with the thing that's most pressing for them. The reason for that is because we want to take something off their nervous system, right? That disturbance, that anxiety, that distress, so that we can actually work on really the underlying issues that maybe have previously put those things into place, those types of responses that are not as healthy as they would like to be, or as kind, or whatever, compassionate, whatever it might be that they're looking for, or relational, the difficulty with the relationship. With case conceptualization in EMDR, it gets confusing because people say, well, gosh, you're going into all the trauma, and that's not trauma-informed, and, well, it is trauma-informed.
Right.
And you are very careful. You're just touching the tops of what has happened in their life.
Right.
You're not diving
deep. Right.
No, you're not going like, okay, tell me every detail about that one. Now tell me every detail about that. What happened? You're just going, it's there.
You're identifying.
You're identifying.
Identifying, right.
And then you have to decide, this is case conceptualization. Where am I going to go in? Where am I going to start? And after I start, and what I recommend to people is really start with what their goal is, because that's going to bring them satisfaction. It's going to bring them the sense that they can actually do this. It's going to, it takes down things off of their nervous system so that they can really begin to function better right away.
Right away. And not only that, but they often feel dismissed if they come in for this problem, but we're like, well, let's look at this other stuff.
Yes.
They're like, well, this is what I'm coming in for.
Yeah.
Sometimes they don't see the connection
when
it may be obvious to us.
That's right.
But still, if we address that, then it also helps their buy-in
That's right.
to therapy and to what else we can help provide them with to, actually let them experience joy,
Yeah.
happiness.
Again, yes.
Right.
That's
because
right.
because this event may be a trauma response because of these other things. But if we don't address this, then they feel kind of dismissed.
And like, why am I don't want to do that.
Right.
Who wants to go back and dig around and everything?
Well, that's a good point.
Okay.
Like nobody does.
Yeah. I don't really either, except that I know full well how
It is
good-
helpful.
Yeah,
It's
for-
and necessary sometimes.
It truly is. I
Right.
mean, especially with the more complex cases. Now, there are going to be times when that happens. But then, okay, what do you do after you come in and you work on this particular thing? Well, again, you have a map. And I'm not going to go into a whole lot of detail about case conceptualization and how you get there and everything, because that's in the training. Too much for today.
Right.
But the thing that stymies people who are the therapists providing EMDR frequently is, then where do I go?
Right.
Okay, so I worked on that one thing. They had a fight. Their boss was rude, or relationships issues, or car accident, or whatever. It may be one thing. Now what do I do? Well, you have a map in front of you. And this is a collaborative approach to therapy.
Sure.
So we're going to be talking about it and saying, okay, we've worked on this one particular thing. What are we going to do next? And if you do your case conceptualization well, it'll be really easy. Like, it'll be the next item on the list.
Sure.
Okay?
Sure.
But even if it's not, you can open it up and say, this is what we've talked about. This is your history. Where do you want to
Where do you want to go now?
Yeah.
Where do you want to go now? Sure.
Yes.
Sure.
What's next? I
Right.
know there's 3 areas that we've talked about in the intake and all of that. So it is not that complex, but people really do get stymied by it.
They
again.
do. And I've worked with clients where we did the most recent,
Yes.
event that's triggered them, that's upsetting them.
Yes.
And they will say, I've done EMDR before with people, and we went back to when I was 6.
Yes.
And we, and I was like, I've dealt with that, whether they have or not. To ours, did they
Yes.
get the level of disturbance all the way down to a 0?
Right.
But that's not for us to decide.
That's
first,
right.
First off, and if we don't address what's bringing them in, the thing that's bothering them right now, they're not going to come back, and we're never going to address that.
That's right. And there's multiple reasons for using what is it they're coming in for.
Right.
Right? Because again, that they can have a sense of accomplishment. They can think this stuff is really fantastic.
Yes.
And it isn't about hooking them. Sign
Sure,
language
sure.
is like,
Sure.
addiction. It isn't about that. It is about getting them relief.
Sure.
Okay, get them some relief from their suffering.
Yes.
And I like this point too, and it is not. And I want to return to this other point. Look, we are not driving them to do something. We are not trying to trick them into liking EMDR. We are, in fact, on the very phone call, when they call in and they tell me I'd like to come in from EMDR, I ask them questions and I inform them. One, what do you know about EMDR, and what have you heard? Okay. Well, I've heard you can fix it in one session. And I'll say,
Right.
well, that's not exactly true.
Right.
Okay, and so I can inform them. And then guess what's going to happen? You're going to come in, and I'll tell them this. You're going to come in, we're going to do a couple to 3 sessions or more, depending on how severe your life has been, what kind of complexity your trauma is. And so we'll do that for as long as it takes, and then we're going to do something else that I call happy, happy, joy, joy, which is establishing a safe place. And I'm not trying to go through the whole thing.
I
but-
love that you call it happy, happy, joy, joy.
Yeah, that's what I say. This is about happy, happy, joy, joy. So
I may change that now. I just
well-
call it a safe calm place.
Yeah, well, they love it because
Yeah.
they kind of leave happy and
Yeah.
joyous and calm and different than when they walked in.
Right.
So that's another little taste.
Happy, happy, joy, joy.
Right. And then we're going to start on the trauma.
Then we're going to deal with the trauma.
Yeah, because we need to know that, look, they're stable enough that they can change state, which is meaning that they can be aroused and depressed or whatever it is they're here, and then they can actually go to this fabulous place that they've used in their mind. It's a tool that we teach them so that they can take themselves into another. It's a little bit about the anxiety stuff that we were talking about.
Right.
They can take themselves to another place,
Right.
and their whole nervous system can regulate.
Right.
And
Right.
so it isn't about you dive in, you hit it hard, you fast,
Right.
you're going too deep. They're freaking out and they have to go to the hospital.
Right.
It is very much a collaborative approach, and one that you are watching every step of the way to make the determination about where you go next, and they are informed from the get-go, from the first phone call that they get.
Right.
And as the therapist, you've got a map.
Well, one thing too, you mentioned, we would go with what they come in with. We're going to target first what they come in with, what their presenting issue is. I've often found, and you've done EMDR far more than I have, but I've often found we will do that, and guess what gets brought up?
Yes, that's right.
I have a client who was, a situation that produces some anxiety with his spouse, and we were talking about a spouse, and lo and behold, my dad.
Yes.
This reminds me of something with, and it's like, oh, interesting. Of course, I'm just going to say, well, notice that, And so sometimes we do end up back there, and it's where his brain needed to go for healing. We've used that phrase a lot.
Yes.
But he wanted to target this situation that, creates anxiety for him, and that's where we start. Now there's another term that's been brought to my attention. I had one client, we did many sessions of EMDR, and we were all over the place, and the negative cognition was, I am a failure, and it resulted in something fairly recent with which was what brought her in for counseling with family. And we ended up addressing work and childhood and all this. And you called this term spaghetti bowl. But I think that's a good thing to talk about while we're doing case conceptualization.
Absolutely.
Right.
There's so much that happens. And one is informed consent. You brought up this thought about informed consent. So if you have a map, you can go, this is actually going to go back to mom or dad or whatever. And so you take the time to say, hey, and also, by the way, when we're teaching, that we know that this stuff in the past set the groundwork for the whole future.
Exactly.
So there is, when we're doing EMDR, just to kind of put this in there too, not for you to think that we just go for what's happening in the moment, that we usually start with the first or the worst situation. But you have to make those determinations. I just didn't want you to think that you that's the way it's done. And there's more to it than that, right? This is a 6-day training and all that. Okay, so there's that. And I like to tell them, this public speaking issue comes from your mama. And this is what happened. And this is where it got laid down in your neural network. And as a result of this, we don't know, because your brain's so crazy. I call it, the spaghetti bowl, or spaghetti brain or whatever, because there's so many connections, millions of them in your brain, and we don't know what all is connected.
Right.
So what are we going to do? This is how I talk about it, informed consent. What are we going to do when mama comes up? Because you told me, I don't want to do mama. I don't want to do my past.
Yeah.
Fine. This is your perfect right, but what are we going to do about it?
Right.
So I say, if this happens, I'm going to stop doing what we're doing, which is working on something in the present. And then I'm going to just say, hey, mama came up. And what do you want to do about it? Do we want to lock it back down? And that's fine. And it truly is.
Yeah.
Right?
Yeah.
Or do we want to go for it?
Yeah.
Because it's here.
Yeah. It's shown up.
Yeah, it's shown up.
Right.
And as I said, it's attached. And we don't know what else is attached to that.
That's a good point. We don't know what all else is attached.
No.
And it's almost all attached.
Yes.
And another thing too, that you've said is, every brain is unique.
Yes.
Everybody's brain is unique as your fingerprint, and we all have our own unique fingerprint.
Yes.
And so we don't know how they're going to process it.
No.
We don't know what their triggers are. And it will touch on that. It will almost always, something from the past will almost always come, and it may even come up in the way that they just say, I wish people would just listen to me.
Yes.
Okay, well, they're talking present. They're also talking past. You know, that's all related.
That's so related.
Right.
And so if we have the luxury of time,
Right.
and they are in it to win it, or
In it to win it.
then I kind of think, okay, we're going to get to it all.
We will get, you're right.
And you can unwind it. So this is again, going back to the complexity of case conceptualization and why people have difficulty with it, because they go, wait, there's all this stuff, where do you start? And then you get this present stuff done. Well, guess what? We haven't done any of the past on this present issue even. We haven't gone back as we do and look at where did it start. And so you have, literally, we have a way in which we have a little ladder that the therapist can use and know what to do next.
And it's not that we're trying to just lock clients in for
Yeah,
long-term therapy.
that's what I even tell them.
Right. It's like we can stop whenever you're at a happy place. Like you're
Yes.
good with it. So we take what we call it a SUD.
Yes.
It's a level of disturbance from a
Subjective.
0 to a 10. 0's no disturbance. 10 is the most disturbance they can imagine. And we'll ask them when they describe, whatever the event is that we're targeting, how disturbing is it to you now? And some will say it's 20.
Yeah. Yes.
So it's very disturbing still. And, our goal as the clinician is to get it to a 0. And of course, some of them are like, that could never happen because it was a rape or somebody that died, and I'm like, that doesn't mean you're okay with it. You're not, it doesn't mean you're okay with what happened. It's just how disturbing is it to you? So there's some psychoeducation.
Absolutely.
But sometimes they're okay with it if they get it to a 3 and they're
Yes.
like, I'm good.
Yeah.
And then we say, okay, we're going to take that,
Yes.
if that's okay. We still would. So you also say in your trainings, even if they get it to a 1, and Dr. Shapiro used to say, if you get it to a 1, you're okay. But Dr. Christie says, there's a root there still, and
Yeah.
something will grow from it if you don't get it to a 0, right?
Right. And
Yeah.
I don't let them know that I have an agenda. But I will say, because of my experience, it's true.
Yeah,
And
yeah.
and you can stop at a 1 or 2. It's in her book. It's in everything that I've ever taught.
Yes.
But what I've learned in my clinical
Yes.
application is that a 1 or 2 could be 5 sessions long.
Right.
That if we don't get that 1 or 2 out, that it's like this. I use this as sign language. I use a lot of sign language. I used to sign. Used to just whatever. But anyway, so here comes you don't get all of
Right.
the root, then
Right.
it's going to come up in the next spring rain.
Right.
So how do we address that? And I'll do it like this. I'll just tell them.
Okay.
What I have experienced is that 1 or 2, even though you feel great,
Right.
that 1 or 2 can be 5 sessions worth of work that can put you beyond this memory. This might have it lingering a little bit. It might get triggered by something else that happens in your life. And while you're here, would you be interested in just seeing what happens?
Yeah, right.
Because they don't know that a 1 or 2 still could be that rich.
Absolutely.
Right? They
Right.
don't.
No, because they see how much relief they've had
Yes.
from the beginning.
That's correct.
And they're like, this is just so much better. I'm good with
yeah,
this.
exactly.
Yeah,
Exactly. They don't know.
Yeah. So the other thing I thought I would bring up when we're talking kind of case conceptualization and just some psychoeducation, informed consent, you talked about happy, happy, joy, joy.
Yes.
Also containment.
Yes, absolutely.
So when we get them activated,
Yeah.
well, let me just rephrase. We don't get them activated.
Yes.
But they get activated.
Yes.
And we've had our session, and then when we've already prepared them because we've in the first sessions before we start the bilateral stimulation and go addressing the target. We've already informed them about a containment exercise, and we've informed them about safe, calm place,
Yes.
or happy, happy, joy, joy, so that they can, in between sessions, regulate.
That's right.
Self-regulate.
That's right.
So, talk for just a second here about the containment exercise. How do you inform your clients about that?
Okay. So there are so many ways, and all of us as therapists have learned how to do containment exercises, whether that means you have little boxes and you can, put something in that box and leave it at the office with me, or it might be, a drawing, or it might be a real place on this planet where you go and it's sort of like your place on Earth. It's the calm, and it's usually a place in nature. You were talking about that in one of our podcasts. So you do whatever one does, whatever your skill set is, what you have learned in all your years of doing therapy, to calm the nervous system down. Whether it's diaphragmatic breathing, I talked about this with anxiety,
Right.
changing your parasympathetic nervous system to engage in the sympathetic nervous system to engage the parasympathetic nervous system. So anyway, you teach them all these wild and wonderful skills, but it is really based on their need. There's something we call, I won't go into the broad containment exercises that there are, but they're lovely. And really it is about closing down their neural network again. And you're right, we do actually activate the memory.
Right.
And all the components of the memory.
Exactly.
Right?
All the components of the memory.
What we're not doing is forcing them, you face it and you say it again and again and again, right? We are just saying
We
we're
don't
going
do
to
that.
activate it, and then we're going to start working to move that train down the track and unload some of that off of your nervous system.
Sure.
So, did I answer your question?
Yes. Another thing too that I do with clients is I actually have them create in their mind a container, a box.
Yes.
Yes. So because I say these things are going to come up, we've already got your nervous system going. The train's rolling down the track, or the cruise ship is out of port. It's set sail.
I like
Here
that.
it comes. And, you may I often have clients that report, they've had nightmares after we've done EMDR, because they're activated. So I just try to tell them I want you to just make note of it.
Yes.
Use a containment exercise, use the safe calm place to self-regulate, make note of it, put that in your box. I've had some, I live in Arkansas now, so I have a gun safe.
Yeah, yes.
And it's got 5 locks on it, and I
That's
just
right.
open it up, throw it in, and I lock it all back up,
Perfect.
And then next week when I see them, we talk about how did it go, and they're like, I got a lot of stuff in my safe, and sometimes I have one lady that literally decorated a tissue box.
Yes.
And had a little slit, and she would write it on a little note and
Yep.
put it, and it was like, it's safe, and I'll talk about it with Dr. Deborah when I see her next.
Yes.
And I was like, awesome.
That is awesome.
And really, I found we really don't have to even really talk about it. We just take off where we were at.
Yes.
We're not even where we were at, but where they're at now.
Yes.
Because
That's right.
kept
The train
moving.
keeps moving, though they're not in here.
Right. So, that's kind of important too when we're looking at case conceptualization. We don't pick up where we left off next time.
Right.
So we've already got this, we're targeting the memory, we're working on it with them. And when they come in, it's like, where are you at now? And a lot of work may have happened between them.
That's right.
They
could be in Hawaii. They could be in Guam.
They have set sail.
Yeah, they're on a world cruise.
Right.
Yeah, that's exactly right. It just keeps going, and I can't help myself, but it's like I try not to scare anyone with the containment exercises and that kind of thing. Not that I don't use them. And not everyone needs them.
Right.
Okay, some people
Sure.
can just do the happy, happy, joy, joy, safe, calm state or safe, calm place. Some people can do, there's another one that we call resource development installation, where there's a moment of time when they just went, yes. And okay, so that's lovely. They can empower themselves. They can remember whether it is, I remember when I learned how to tie my shoe. I was so proud of myself. It doesn't matter. Everybody can find a moment that they were proud of themselves. I believe so, or that they felt that power, or yes, I'm capable. I did it. I got that job. I made that A. Whatever it is. So there's multiple ways of doing containment, and I even like. People mention that EMDR has lots of components of CBT, of meditation, of this or that, mindfulness, because we're asking, what are you noticing now all the time, right?
Right.
And so I've had people ask me, Christie, is it okay, or Dr. Christie, is it okay with you and EMDR if I interject some of the things that I do with my people in my office? Like I have them meditate a little bit, and maybe we have a couple of quiet moments, and whatever it might be, send them to yoga, do it. Whatever you do as a clinician and you think this person would benefit, have them try it. So anyway, it does have a component of so many different
right,
types
and
of-
it lends itself to some personal, preferences or skill sets, or
Yes.
so the clinician can. It's not rigid. And it's fluid. It's a fluid process.
That's right.
But there's in one of the episodes we're gonna do, you're gonna show the phases, and we'll talk about the phases
Yes.
of EMDR. But it's nice that, like you said, we have a roadmap. We have an idea of what it's going to look like, which is really kind of nice, especially for new clinicians. I'm going to
Yes.
make sure my student interns watch this episode.
Okay, good.
Because so often they feel like I have a degree and I have a license. Now what do I do? With EMDR, they have that. They have this roadmap.
Yes, that's right.
And then if they're going to do certification after they do training, they have these consultation calls and getting some input, and they do a lot of case conceptualization in that.
Yes.
And that just helps them grow as a provider. It helps them grow in their confidence level in what they're doing.
I just feel like everybody should become certified. There's a couple of reasons for that, and certification, that's a whole nother topic, but the reason why I think that is, over my years of experience, again, I have noticed that people get trained and then they go, I don't know where to go
Right.
next, and so they stop using
They
it.
stop using it, right?
Because it's difficult to start something new,
Yeah.
right?
Yeah.
And especially if you're accustomed to, one type of therapy or
Sure.
therapeutic
Sure.
orientation. But what happens is, over that period of a year, people gain confidence in themselves, the therapists themselves, and they begin to use it a little bit, and they're hearing other people's experiences and things. It gives them a little oomph. Oh my gosh, you can't believe what I just happened in my own therapy session, or this or that or that. And so it's a safe place. But I'm telling you, that year is sort of like a leap year into.
Yeah. I was thinking growth,
Yes.
Such growth.
Yes.
In your ability to use EMDR, in your confidence in using EMDR. You'll try things. You'll come in and you'll go, this is the situation. And then, you're doing your certification calls with somebody who's practiced it.
Yes.
And so they may say, oh, let's, here's something you could try. It's
That's
just
right.
so helpful. It's just a little bit like supervision. But
Yeah, it's a lot like supervision.
Yeah.
It
Yeah.
really is. And real cases, and encouraging people to use it. But anyway, that's
Yes.
that's
So if you're looking for certification, give us a holler.
we're available.
All right. Well, thanks for talking with me about case conceptualization.
Thank you. Thank you
Yes.
for having me.
Yes, I hope you've learned something new, and we'll see you in the next episode. If this content has been helpful to you, I'd appreciate it if you would please rate the podcast, post it, and share it on social media. And also post a review. If you'd like to get in contact with me, my phone is 479-561-7600, or email Dr. Deborah at anchoredhopecounseling.net or Dr. Deborah at drdebfordoctors.com. Our website at www.anchoredhopecounseling.net has some useful information, and you can also reach out to me through the website. Remember, you are enough just the way you are, and you are loved.